Assalamu alaikum. Thank you very much. Yes, I'm his new partner, so he used me right away. He said he couldn't come. So this is actually his case and his slides. I talked to him about it. So inshallah, I'll be able to answer most of your questions. It's a very interesting case. So we don't have any disclosures related to this case other than that it's not my case and it's his slides. So this is a 44-year-old female, pretty small BSA of 1.9. Her background is at age 30, she had a bicuspid aortic valve stenosis that was replaced with a 21 mitral flow. She also had type 2 diabetes and high blood pressure. Her post-surgical echo showed quite a bit of patient prosthesis mismatch with a gradient of 30 and effective orifice area of only 1.3 with an indexed area of 0.68. So right off the bat after her surgery, she has quite a bit of patient prosthesis mismatch. Fortunately for her, she did very well for 15 years despite these hemodynamics, and she was NYHA class 1 for a long time, for 15 years. She now presents with progressive shortness of breath and NYHA class 3 symptoms, orthopnea, PND, and shortness of breath with exertion. So this is her echocardiogram. You can appreciate quite a bit of LVH and a velocity of almost 6 meters per second and a mean gradient of 90. So our CT TAVR or cardiac CT scan showed a 21 mitral flow with an inner diameter of 17, which goes again with a 21 mitral flow size. You can see the sinus of Valsalva. It's pretty effaced. She's not a big lady anyways, so it all goes along with that. Her STJ is 24 by 26, and her LVOT is very, very small. It's almost elliptical, 13 millimeters by 23. And this is the rest of her CT measurements. Her ascending aorta is not that big. It's maximum 35 millimeters. Her left main is about 9.8 millimeters. And if you remember, the 21 mitral flow has a height of 17 millimeters, the post of that valve. And her RCA is about 11 millimeters, and her STJ height is about 18 to 19 millimeters. This is, again, some of these other measurements. Her angle is only 47 degrees. Her STA score, despite the redo status, is 1.2%.
Okay, thank you, Doctor.
There are a lot of questions, obviously, when she was 31 years old, why she didn't get something different, but I guess the answer to that is that the patient wanted to get pregnant and she did not want to have a mechanical valve. So,
I mean, even the other question, people are going now from the surgery perspective with annular root dilatation to have a more better, because I don't believe there's something called benign prosthetic mismatch. So, Dr. Tariq, what do you think? What is the best option now? We're in a tough, tight spot.
We are in a tight spot. And I know this is a TAV and SAV session, but I would give serious consideration for a redo SAVR with a root enlargement. She's 44 right now.
Yes.
So she will need something in the future. And I think giving her a platform that will accommodate a larger TAV and SAV in the future is probably going to be a reasonable choice at this point.
How difficult do you think would be a root enlargement redo procedure in a small female would be at this point after you have a SAVR in there? I mean, we would love to have a surgeon comment on this, because my understanding is it will be pretty difficult to do a root enlargement with this anatomy right now.
It usually is. And I have a couple of patients like this, and I argue with the surgeon about this all the time. And they look at me and they say, this is the biggest valve I could squeeze into that annulus. The root enlargement is a more extensive surgery, but it's a small investment for a long return.
Yeah. So, Dr. Amri, what do you think? We have the discussion. Looks like we're swinging towards surgical arm, but you talked to the patient. She said, no, I don't want surgery, no matter what.
I think I'll ask the surgeon to go and talk to her.
Talk to her.
I don't think she's really a good candidate for valve and valve. She already has a patient prosthesis mismatch. The gradient is high. You will, deploy a smaller valve into a stenosis
It
small
is a
valve.
spot.
So I think we are calling for trouble.
So we call the surgeon. The surgeon is in the room, and she still said, no, get out of the room. Dr. Ali, I don't want surgery. Give me another option.
Well, I would say I wish she had a mechanical valve in the first place. At that time, she was in her 30s, early 30s.
But she wanted to get pregnant.
Yeah.
But she always.
That's why they didn't do it. Right.
So I completely agree. I think reduced surgery would be my recommendation in this case. If I was going to go with a valve-in-valve TAVI, I would consider fracturing the old valve, because this is a fracturable valve, the mitral flow. I usually do it after putting the new valve in as opposed to before. The other thing I would consider is using a self-expandable valve as opposed to a balloon expandable valve, because this is a small annulus, and I do worry about hemodynamics and future issues.
So, Dr. Mahmoud, there is no time machine, so we're not going to go in the past. He brought you the self-expandable valve in the room. What is your next step now? Any precaution
I
like
mean, I wouldn't do this case.
You will not?
I would send him to a surgeon. I mean, this patient should get a Ross, should get some kind of a root enlargement, because whatever we do now, we're going to pay the price in 10 years. Okay, even if we get a good result, we put a mitral flow, she's got a small sinuses, small STJ. This valve is likely going to fail relatively soon, and then she's 52, and then we're trying to figure out the next step at that point. So I would do everything in my absolute power not to TAVR her.
no?
That being said, I would probably go with a self-expanding valve.
Yes, yes, doctor. Oh, we have a surgeon here in the room. Okay.
I think sometimes we have to know how to say no. Even if the patient insists, we can insist also. No is no.
So this is the difficult thing. Like, if the patient said no, should we also say no, or should we give the inferior alternative option? So, Doctor.
Thank you very much. I think I'm really very happy to see how mature the discussion become over the last few years. I think we have learned from the past years in terms of patient selection. This patient particularly, maybe she chose to have a tissue valve in all days because she wants to be pregnant for whatever reason. But now is the time that she will have a long life management, and we should put surgical options up front to have. There's no discussion, because otherwise, if she knows the consequences, and I come across every week these cases, if she knows the consequence and she's being talked to, patient always accept what you tell them. You don't manipulate them in terms of risk and incision and so forth. And the emphasis now on minimal invasive options make the discussion much easier. So I think patient-centered options in this patient is really what we should be going for.
I would like to ask you, doctor, let's say I did it. I put a self-expandable valve in her, and she came after 10 years, 12 years, and now I called you. What should I do? How risky is the surgery now with explantation, and this will be the first redo in a TAVI and SAVR with a long frame?
Yeah.
How much of a risk now we should tell her? Like, we're talking about frank discussion with the patient.
I think the risk of surgery is much less nowadays. And I believe that root enlargement was not done in the past as a routine for these small root patients, but I think becoming more and more routine procedure of the root enlargement. And I don't see now the discussion should be for young age like this, whether we should do TAVI or we should do surgery.
So, Dr. Qintar, I mean, do you do CT upfront for any young patients for going for, let's say, SAVR, or we go the conventional way in your center?
So honestly, I was before I came to Qatar 2 months ago, I was lucky. I practiced at the University of Michigan, which we have one of the best surgeons for TAVR explants, and we have one of the best surgeons for root enlargements. The Y, Dr. Boyang, I mean, he created the Y technique, and we are lucky that people could do that surgery easy. However, I can tell you that in the United States of America, you can count on one hand the number of surgeons that are comfortable doing small females with good outcomes. I remember in my fellowship, we sent a small lady, 63-year-old, for a root enlargement SAVR, and she ended up on ECMO for like 4 weeks. And I think sometimes you are as good as your last case, and you think too much about these things. But I think a root enlargement with an LVOT of 13 millimeter, she's not going to end up with, I mean, who knows? But I think right now, in this day and age, if you're going to end up doing anything, you have to CT people and you have to plan 2-3 more, valves down the line. This one, Mohammed told me they offered her many times surgery. They declined her TAVR multiple times. And she just said, if you don't want to give me a TAVR, I'm going to travel somewhere else and get a TAVR. And in fact, this is not just in this region. I remember 6 months ago in the US, I had a teacher, she's a principal, and she was 51 years of age, bicuspid aortic valve. And we said, we're not going to give you a TAVR, you need to go to surgery. And she said, I will travel the world for a TAVR. I know exactly what you're saying, and I understand everything you're saying. I do not want surgery. And we ended up doing a TAVR on her, she's 51. But is it ethical to say that I do not want to give you a TAVR, knowing that that option is inferior, but that option actually exists? I don't think as doctors you have the right to say no multiple times, especially if the patient is 100% consented. So this patient, she refused surgery by multiple different times. She was seen by different surgeons, and she just did not want surgery. So we surrendered for TAVR. We obviously expected PPM. Remember her post-surgical echo in 2008, she had a gradient of 30.
Yeah.
So that in mind, obviously we're going in knowing we're going to fracture this valve as aggressive as possible. We have to give her the best result. And I don't think in this case you're going to go with the balloon expand. I know the panel didn't discuss that. I don't think you're going to put a balloon expandable valve in this valve. You're going to put a tall frame, supraannular valve.
Show us what you did. You can proceed with your case. Because we're short in time, we have 7 minutes.
Right. We'll be done hopefully in 7 minutes. So they implanted a 23 Medtronic Evolut valve, and it looked horrible, obviously, from the first deployment, because you're putting a 23 circle into a 17 millimeter circle. And on the table echo, the mean gradient was 50 with a Vmax of 4.7. So it's a little better.
So you fracture before or after you do?
No, we fracture after, obviously.
Fracture.
Yes. Yeah.
I mean, I would have implanted it a bit lower, keeping in mind that I'm going to post-dilate or fracture. But keep going, Doctor.
I think I would have loved to have a deeper evolute, knowing that you're going to go full-blown fracture in this case. But I think the idea was if you are higher, your hemodynamics are going to be better. So they try to really nail it down to the millimeter to get her the best hemodynamics. So 20 millimeter Atlas Gold at 12 atmospheres fractured the valve. And your mean gradient now is 19 with a Vmax of 3. And this is her 2-year follow-up echo. She's NYHA class 1, and your Vmax is 2.5, which I think this is a huge win, to be honest with you, starting with what you started with. This is a patient who really got lucky with good hemodynamics at 2 years. Now, when she comes back for a third time, we'll see what the CT looks like. But the summary of this case, choosing the proper prosthesis type and size, the first operation is crucial. And I think I'm not speaking on behalf of the surgeons, but one of my surgeons told me they learned a lot from the TAVR space. The surgeons now practice differently. Even when they are thinking about surgery, they plan for the TAVR operation or the TAVR procedure from the first surgery. They put the biggest valve possible. And redo surgery should be the first choice in this particular patient if they agree to this. And for TAV and SAV, especially for smaller prostheses, very careful pre-procedure planning is required to avoid PPM and coronary obstruction, coronary access impairment. In fact, you guys all know about these softwares now, the DAISY software, all these other softwares that are coming up to help us plan for the second and the third.
Yeah, we have, I saw Dr. Tariq opening, in the last 2 minutes. I would like to thank you so much for the case. It's a very complex case. But he was talking about the softwares. We have the valve-in-valve software, and now there is the redo TAVR software. So with your final comment in the last 1 minute from each panelist.